Welcome to the Veterinary Rehabilitation Podcast, where we aim to help fellow veterinary rehab therapists increase their knowledge and elevate their practice. I'm Megan Kelly.
And I'm Ane Lloyd. Together, we bring you the latest insights, research, and information in the field of veterinary rehabilitation.
This podcast is brought to you by Onlinepethealth, a leading continuing education membership for veterinary rehabilitation therapists. With Onlinepethealth, you'll have access to a wide range of online resources to help you stay up to date with the latest techniques, advances, and trends in the industry.
Our podcast features in-depth conversations with leading experts in veterinary rehabilitation. They share their own experiences and knowledge to help you improve your practice. Whether you're a seasoned pro or just starting out in the field, our goal is to provide you with the tools and the insights you need to succeed.
So join us as we explore the exciting world of veterinary rehabilitation and help you take your practice to the next level. Hey vet rehabbers! Now TENS is widely used in canine rehabilitation as part of a multimodal approach to managing pain, but how effective is it when it's used on its own? Now this episode we explore a research paper that investigates whether TENS applied over a 10-day period can meaningfully reduce pain and improve lameness and gait parameters in dogs. Ane takes us through the study in detail and highlighting key findings and all the limitations. The Vet Rehab Summit is coming up on the 8th of November, and we're so excited to bring you a full day of expert insights, inspiration, and connections, all from the comfort of your home. This year's theme is Dynamic by Design, and we're going to explore canine and equine anatomy in motion. We're going to dive into biomechanics, muscle activation patterns, and movement science that you can apply in practice right away. Now, we have free live tickets. Spots are limited. If you want full access to the lineup and all the sessions recordings afterwards, now's the time to register. You can check out the program, save your seats, go to vetrehabsummit.com. A quick word from our sponsor before we dive into today's topic. At Paw Prosper, we believe true pet well-being demands a three-pronged approach: prevention, support, and rehabilitation. Our brands are trusted by veterinarians, universities, and rehab facilities alike. So whether you're looking to train, rehabilitate, or help your patients age gracefully, our brands Walking Pets, Help Them Up, Respond Animal Therapeutics, Fit Paws, Muffins Halo, Sleepy Pod, and Canine Carts offer effective, innovative, and proven solutions. You can sign up today to receive a one-time special gift. This is for all our podcast listeners with your next order, and just need to go to the special link, pawprosper.com/OPH. And of course, you'll be able to see Paw Prosper and all their brands on the 8th of November at the Vet Rehab Summit. Right, over to Ane.
So today we're going to look at the effect of transcutaneous electrical nerve stimulation on gait parameters in dogs with OA, and I hope that you enjoy that. Right, so I always really like that the Animals publication does this little simple summary, but this paper is by Pedersen, Hutianen, Roden, Forterre, Pennell, and Anna Berg. So, Heli Hutianen and Anna Berg are some of our lecturers that have been on here before, and they're really great clinicians and research people. This is a 2024 paper, and it's published in the Animals Journal. TENS, or transcutaneous electrical nerve stim, is used in dogs as a pain-relieving treatment. This randomized, single-blinded crossover study aims to investigate whether treatment with TENS will affect gait parameters in dogs with osteoarthritis. They had 15 dogs included in the study. All dogs were over 1 year of age, lame, and they had chronic pain for more than 3 months. Dogs were treated with TENS for 7 or 10 days, and their gait pattern in trot was evaluated with a pressure-sensitive mat. In the present study, no significant differences were seen between TENS and placebo treatments for any of the gait parameters evaluated by the pressure-sensitive mat. Further studies are needed to confirm these observations. So really everything we need to know just summed up there in a nice way. Okay, so we know for osteoarthritis, very common in dogs. It usually manifests as pain, joint swelling, reduced mobility, causing varying degrees of lameness, affecting function. So there are several treatment strategies for OA, which includes pharmaceuticals, nutraceuticals, weight reduction, regenerative medicine, therapeutic exercise, and different rehabilitation modalities. It's likely that the management of OA may benefit from an integration of both pharmacological and non-pharmacological treatments. Common pharmaceuticals for OA includes non-steroidals, corticosteroids, and monoclonal antibodies. I thought this was interesting. In 55% of the studies on NSAID safety, adverse effects were reported. Right now, I think it's interesting that they state it like this: 55% of the studies on NSAIDs, adverse effects are reported, because that's not saying 55% of dogs on NSAIDs. It's saying that 55% of the studies done have reported adverse effects. So my question is, what percentage of dogs who are on NSAIDs actually have adverse effects? Are they severe? What are the implications of that? So I did go have a quick look at the study, and they pretty much report it exactly like this. Adverse effects were detected in 35% or 35 studies, 55%. This was a literature review. That study was a literature review. So adverse effects were detected in 35 studies, 55% of the studies, and commonly included vomiting, diarrhea, and anorexia. 3 studies reported a power analysis related to adverse effects of more than 80%. In randomized placebo-controlled blinded studies, 39% of the studies, the incidence of adverse effects was not statistically different when treated between the treated and controlled groups. And then finally, most studies were not appropriately designed to determine the safety of NSAIDs and involved a healthy non-geriatric population of research dogs. So I don't think we really have the numbers to say how prevalent side effects really are in the use of NSAIDs. So I thought that was interesting, but tangent, okay. So we do want to find alternatives to long-term use of non-steroidals, because when they do have side effects, it is significant and it does affect their life, their quality of life, their length of life. So it's relevant to study non-pharmaceutical treatments, such as different rehabilitation techniques, as complementary or as standalone treatments for dogs that do not tolerate NSAIDs or corticosteroids, and where treatment with monoclonal antibodies is not feasible. So rehabilitation is considered an important component of an overall long-term treatment strategy for OA. TENS is a modality that we're commonly using as a part of our treatments. It's a device that uses electrical current delivered through electrodes on the skin to stimulate nerve fibers for therapeutic reasons, i.e. pain relief. Right? It has multiple adjustable parameters, including pulse frequency, pulse duration, and intensity. It's claimed to provide pain relief through either an endogenous opioid release at a low frequency tense, or on a segmental level through the use of the pain gait theory, especially high frequency tense. This latter is believed to be effective by applying stimuli to larger diameter non-noxious or alpha-beta fibers, which subsequently reduces pain via decreased nociceptive activity. Studies have also shown increases in B endorphins and methionine, enkephalin in human subjects, a release of glutamate and substance P in animals with inflammation, neuropathic or incisional pain, and a reduction in pressure pain thresholds at sites of TENS and at sites outside the area of application. A reduction in microglia and astrocyte activation in the spinal cord in both OA and neuropathic pain animal models. So really, there is quite a bit of evidence that supports the use of TENS, or that show us, how it's working or what effect it has on the body. In humans, TENS is used as a pain-relieving treatment and complementary or single treatment for OA. A systematic review and meta-analysis of TENS for acute and chronic pain in humans, based on 381 studies, concluded that there was moderate certainty evidence that pain intensity was lower during or immediately after treatment compared to placebo. The review included studies that used participant-reported strong but comfortable tense sensation stimulation with electrodes at the site of pain. However, it's definitely not conclusive. Other studies report no effect on pain compared to control. There are definitely conflicting results. Regarding animal studies, studies report that TENS produced an analgesic effect in rodents with experimentally induced OA. If we look at TENS specifically in dogs, it's pretty sparse. The results from the few existing studies indicate that treatment with TENS may increase weight bearing on the affected limb in dogs with OA for up to 180 minutes after the treatment. A study with canine ankylosing spondylitis showed a decrease in signs of pain evaluated by visual analog scale and clinical exam. A weight reduction study on dogs with OA examined the difference in lameness in two treatment groups, both with a dietary protocol, but with two different physical therapy programs, one of which included TENS. The results indicate that dogs that received an additional TENS treatment showed significant improvement, evaluated with force plate and changes in peak vertical force and vertical impulse, whereas dogs with no TENS treatment showed only significant improvement after 4 months. Okay, so there is some evidence that supports the use of TENS in dogs for the treatment of pain. Right, so 2 of the previous studies have looked at the effect of TENS by using kinetic techniques, so pressure-sensitive mats and force plates. The latter is regarded the gold standard for measuring ground reaction forces. Recent studies have compared the results from these 2 kinetic techniques and reported that they are equally reliable but not interchangeable. Okay, that's important. Further studies have shown a high agreement between repetitive measurements in individual dogs. So pressure-sensitive mats versus force plates are equally reliable, but they are not interchangeable outcome measures. Okay, so these outcome measures allow us to look at different gait parameters, including temporospatial parameters, peak vertical force, vertical impulse, and symmetry indexes. So OA often results in mild to moderate lameness, and kinetic studies show alterations in peak vertical force and vertical impulse, as well as symmetry indexes. Studies that look at pain-relieving treatment of dogs with OA have used changes in peak vertical force and vertical impulse as outcome measures, showing therapeutic effects such as an increase in load on the lame limb, but also redistribution of weight to other limbs. So, due to the increasing clinical use of TENS, together with the lack of research on its possible effects, the present crossover study investigates the effect of TENS on canine gait parameters evaluated with a pressure-sensitive mat. Perfect. So all of that, super good, interesting, positive. I love it. Into the materials and methods. This study consisted of 2 parts. They really nicely outline it here. So let me make this bigger so you can see that a bit better. So they start with baseline measurements. Then they do a randomization. Dogs then go into a TENS and a placebo group for 7 or 10 days. They then have a washout period of around 7 days, and then they swap. So crossover study design, the TENS group becomes the placebo group becomes the TENS group. They then all have another washout period, and then they do 7 days of NSAIDs. So the study is divided into 2 parts. The TENS evaluation part, which is the crossover design with placebo groups, and then the second part is looking at the effect of NSAIDs. So I think that's a really good study design. All right, so they used client-owned dogs of any sex or breed with confirmed OA. They were all eligible. Okay, they sourced them through social media, emails, and advertising in magazines and at veterinary practices in the local area. Dogs were included if they were over 1 year. They had a lameness between 1 and 3 degrees in a trot on a 5-degree scale. And they had an OA diagnosis confirmed by diagnostic imaging. And they had chronic musculoskeletal pain for longer than 3 months, diagnosed by a veterinarian before the study. If the dog was diagnosed with OA in multiple joints, enrollment was based on the worst affected joint. So they did have dogs with multiple sites of OA in the study. Dogs were excluded if they had a metallic implant that interfered with treatment, a pacemaker or a tumor in the treatment area, or a sensory deficit in the treatment area. Dogs were excluded from part 2, so the NSAID part, if they had a history of adverse reactions to NSAID. So that's great. So to me, this design showcases, these are the patients we're going to see in the real world. From my side, I really love when they do this in a study with the study population, because I think it's reflective of what we deal with in the real world. However, from a study design perspective, it makes it, it weakens the statistical significance because your study population isn't truly comparable. We're looking at different joints, elbows, stifles, hips, all the different joints. They don't necessarily all respond the same way to treatment. Definitely, if we're looking at kinetic data, the changes are not the same across joints. And so that makes it, slightly less valuable from a statistical point of view. But okay, cool. So informed consent from the owners, they had ethical permits granted. The study included 5 to 7 visits or measurement occasions to the research facility, depending on participation in the NSAID part of the study. Okay, so registration on the pressure-sensitive mat was performed at each visit to the research facility. The grey ovals indicate a telephonic call. So 2 weeks before, they called the clients, they had an introduction, and they looked at discontinuing medication or current NSAIDs. And that was based on, so they did, at that introduction call, the owner would send in videos, lameness videos. They would go through all the medication. A veterinarian reviewed all of that, and then they said, okay, we're going to discontinue your NSAIDs, and then you're going to be included in the study. 1 week ahead of time, they repeated that telephone call, and they checked that the patients were still okay off their medication. If they were not, they would be put back onto pain medication, and they may be excluded from the study. 2 dogs were on NSAIDs through the course of the study, so that's part of it. But again, they look at videos at this point, and they have that telephonic conversation with the owner. And I believe that the owner filled out the chronic pain CBPI and the Helsinki Pain Index on both occasions, and then weekly throughout the course of the study. So on day 1, this block shows us that they came into the facility. They did inclusion criteria, baseline, clinical exam, pressure-sensitive mat measurements, etc. Day 7, start of treatment 1. They did another pressure-sensitive mat measurement before and after a single treatment, so evaluating that single treatment effect. Then the dogs were treated every day by the owner with either TENS or the placebo. On day 8, they had a telephone follow-up to the treatment period 1. Then, day 7 was the first treatment. Day 8, they do a follow-up call, and then they do 7 days of treatment, right? That takes us to 7 to 10 days of treatment. That takes us to day 17, which ends the treatment 1 period. The owner is performing TENS treatments on a daily basis throughout that period. Then they have a washout period, and then we start with treatment 2. These green blocks, they're in the practice. They're having their measurements taken again. So day 26, start of treatment 2, pressure-sensitive mat measurements before and after a single treatment. Again, reevaluate the next day on the telephone, 7 to 10 days of treatment by the owner, and then that end of treatment 2, pressure-sensitive mat measurements. Washout period, day 47, they start their NSAID intervention. Pressure-sensitive mat readings are repeated. They have 7 days on their NSAIDs. They end their NSAID intervention, and they redo all the measurements. So, honestly, really nice study design, if you ask me. Okay, so they had clinical exam, pressure-sensitive mat measurements, and pain measurement questionnaires with the Helsinki Chronic Pain Index and Canine Brief Pain Index. They used the pain index assessments during the baseline and throughout the study period to ensure animal welfare, especially after eventual discontinuation of medication. But in this article, only results from the pressure-sensitive mat were presented. They didn't look at the results from the pain assessment questionnaires, which I think is strange. Okay, but also we want to keep our study design as narrow and specific as we can, so that's also fair. A pressure-sensitive mat was used, and they used a specific software. The measurements were made within an hour after the first treatment session and within 12 to 24 hours after the last treatment of the whole treatment period. The mat was regularly calibrated. Cameras filmed the dogs from lateral and cradiocaudal aspects. The dogs trotted over the pressure-sensitive mat at a comfortable individual pace. They had the same handler and handler side in the very vast majority of measurements. A valid trial was defined as the dog's correct behavior over the mat and the number of step cycles, a minimum of 2 step cycles or 8 stances. Correct behavior is the dog trotting at a constant pace in a straight line, looking straight ahead with minimal intervention from the handler. The criteria for a successful kinetic data collection was 3 trials in trot. The following gait parameters were registered: stance time, swing time, stride length, peak vertical force, vertical impulse, and symmetry indices based on peak vertical force. They did a clinical exam. The owners filled out the pain questionnaires once a week to keep track of the dog's pain score, and they are instructed to contact the authors if the dog showed signs of deterioration. So they really did monitor for welfare. If there was deterioration, the dogs were removed from the study and were appropriately treated. So I think that's great. Okay, so that first call, they got, the dog's status, medication history, videos of the dog from lateral and cranial view. The veterinarian then assessed the dog's pain medication and whether that could be discontinued. Pain medication was reinstated before baseline if deemed necessary. Okay, so they either went in on pain medication or they were excluded if pain medication needed to be added in afterwards. In part 1 of the study, each dog was allocated randomly into either the TENS or placebo treatment for that first treatment period. Treatments were reversed during the second treatment period. A washout period of 10 days was used between the 2 treatment periods. Okay, so TENS treatment was administered with either one of 2 machines. The treatment programs of the 2 devices were synchronized so that the settings were identical. The skin was clipped precisely where the electrodes were situated during treatment, soaked with water and ultrasound gel to have that transmission substance. They used 2 electrodes, a minimum of 4 centimeters apart, placed on intact skin with electrodes at the site of pain or over nerve bundles proximal to the site of pain. So they had a distal placement and a proximal placement. The first treatment was conducted partly by the animal health staff and partly by the owner under supervision of the animal health staff. So that first treatment is in clinic, they're doing it together, and then the following treatments, the dogs were treated by their owners. They did run a pilot study, just adding that in there. The owner did receive instructions, both verbally and in writing, before each treatment period. Okay, so the TENS machines were set to a constant current with a frequency of 80 Hertz and a pulse duration of 100 microseconds based on previous studies and clinical experience. Intensity was increased until muscular fasciculation occurred in the treatment area's muscles. And then it was lowered if the dogs were uncomfortable, and the intensity was gradually increased during the treatment session to maintain sensation throughout. Treatment sessions were 45 minutes once daily. The treating person kept a diary of each treatment session, including treatment duration, electrode placement, used intensity, and the behavior of the dog. The placebo treatment protocol was identical to the TENS treatment, with the exception that the device was not switched on. Each treatment period's length was 10 days, except for the pilot study where the dogs were treated for 7 days. So, to me, I don't know if that's an effective placebo treatment. If, the device is not switched on, but it's on, it's placed onto the dog and the owner sits there for 45 minutes. Again, I actually really like how they set this up, because it is basically what I would do if I wanted an owner to take home a TENS machine. I would have them use it every day. I don't know that I would use a 45-minute session once a day, because that can be difficult in terms of compliance for the owner and the dog. I might recommend 20 minutes. However, 45 minutes is supported by the research, so it's not wrong. It's just thinking about how I would apply this in clinical practice. That is a long time period for my owners to be sitting on the ground with their dog applying the TENS every single day. How would you do it? Does this reflect how you would use the TENS unit in clinical practice? It certainly does for me. Okay, and then the other thought that occurs to me is that, the owner isn't blinded to the treatment protocol. In this case, how would you blind the owner to the treatment protocol? They don't really speak about who is and who isn't blinded. So the person evaluating the kinetic measures, are they blinded to the treatment group that the dog is in? I don't think they stated that. The owner's not blinded, so there could be some bias creep through, and that would definitely be relevant if we were looking at those pain questionnaires. That owner bias could for sure be affecting those scores, but the kinetic data, not so much, right? So, okay, let's carry on. NSAID treatment, firocoxib was administered orally by the owner once daily for 7 days after the finalization of the TENS part of the study, and the dosage was administered according to the recommendations of the manufacturer. We're going to just skip through the statistical analysis. Looking at the results, they had initially 38 dogs selected for the study. That was reduced to 26 who matched the inclusion criteria, and then at the end of the day, 15 of those dogs were used in the final study. In part 1, TENS and placebo intervention, one of the dogs received 7 days of treatment, and then 14 dogs received 10 days of treatment. 2 of the dogs were treated with NSAIDs during the whole study, and that was taken into account during the statistical analysis, so it should not have affected their results, apparently. Electrodes were placed at the site of pain in 14 out of the 15 dogs, and then in one dog it was placed over nerve bundles proximal to the site of pain because of the size and the location of the dog. So we can go through all the dog's data if we want to, but basically an 8-year-old beagle, 13 kgs, 1 degree of lameness in the left hind, OA stifle left hind, cruciate ligament injury left hind, dorsal placement, 7 days of treatment, no NSAIDs. 8-year-old Labrador, 31 kgs, 2 degrees left hind lameness, OA in multiple joints, the metacarpal phalanx 4 and 5 left front, phalanx 5 right front, and the elbow left front, 10 days of treatment, and was on NSAIDs throughout the treatment study or throughout the treatment period. So comorbidities are common. 10 days of treatment, no NSAIDs. Okay, so you get the gist. This is reflective of what we see in practice, right? Does that affect the outcome? I mean, absolutely, right? If we're only using TENS over one joint, sure, the joint that is most, causing the most problems or the most pain, but it is still going to have an effect. Okay, so gait parameter results. Lots and lots and lots of data collected. There was no significant difference between the TENS and the placebo treatments for stance time, swing time, stride length, peak vertical force, and vertical impulse for any of the limbs. Similarly, no significant differences were seen comparing before and after NSAID treatment for stance time, swing time, stride length, peak vertical force. However, there was a significant increase in vertical impulse for the ipsilateral limb before and after NSAID use. Okay, so I mean, what does that mean? We know NSAIDs are effective over over a 7-day period, you should have a reduction in pain that is significant enough to see a change in gait parameters. So I think this is interesting, right? I definitely have questions here. So no significant differences were seen for the symmetry indexes, either for single or multiple treatments between TENS and placebo treatments. The NSAID treatment period showed no significant difference between before and after for any of the SIs. Okay, so this is all the measurements. I didn't go through their tables. This is the SI, but they were not statistically significant. Okay. All right. So the results show no significant differences in peak vertical force, vertical impulse, or SIs of osteoarthritic dogs when treated with TENS compared to placebo, nor were there any significant differences in temporospatial parameters such as stance time, swing time, stride length. So again, my question comes back to, what do I do with this information? Come with me to ChatGPT and let's see what it thinks. And I will still tell you what I think. Okay. So when I use ChatGPT, I tell it what I'm doing, I want input on, and I ask it specifically the points that I want input on. And then I always say, do you have questions before I share more information with you? And then ChatGPT asks me a bunch of questions. I answer them, I give it the article, and then here we go. So my first question is, how do the results from this paper differ from previous studies and why? This is a significant thing. This paper is comparable to previous studies in their methods, but the results do not match up. Okay, so this study found no significant difference in gait parameters between TENS and placebo treatments in dogs with OA. This contrasts with the only prior comparable canine study by Johnston in 2002, which found a significant increase in weight bearing immediately after a single TENS treatment measured via a force plate. So why? What are the reasons for this? The measurement tool, Johnston et al. Used a force plate considered the gold standard, while Pedersen et al. Used pressure-sensitive mat. Remember in the beginning we said that these methods are both reliable, but they are not interchangeable, and they can vary in sensitivity to subtle changes. Johnson's study included only 5 dogs with stifle OA. That is a very small sample, but it was all one joint. This study included 15 dogs with a variety of OA sites, which could dilute the treatment effect across joint locations. So again, we're saying, all right, 5 dogs in my sample group, but it's all in the stifle, versus 15 dogs, but we had shoulder, elbow, metacarpals, back, hips, stifles, too many joints to really compare. And so really our sample group is much smaller per OA site in this study than it was in Johnston's study. Treatment parameters, Johnston used 70 hertz for 20 minutes. This study used 80 hertz for 45 minutes. The different frequency, intensity, titration, and duration could yield different outcomes. So for sure, but the time period, the hertz are pretty similar. I'm pretty happy with a change of 10 hertz between treatment protocols, but the time is very different. So it's actually interesting that our more effective time was 20 minutes, potentially. The timing of measurements, both studies measured gait changes within 1 hour post-TENS treatment, but individual variability and pain source could affect how rapidly or obviously gait changes manifest. Okay, so then I asked, are there flaws in the methodology or statistical analysis? And GPT says, the strengths are, this is a crossover design. Each dog acted as its own control, reducing between subject variability. Single blinded to reduce bias, so I missed that, but ChatGPT picked it up. Consistent handlers and velocity control, good attention to standardization. Statistical controls, linear mixed effect models with velocity, weight, age, and concurrent NSAIDs used as covariates are appropriately applied. So actually really good. The limitations of the study Sample size of 15 may have limited the power to detect small but clinically relevant effects. Owner-administered TENS introduces variability in technique, adherence, and exact electrode placement. That is true. I think that shaving the site of the electrode placement did reduce that, the variability in placement. The owners keeping a diary would have reduced variability in adherence. So I think that kind of cuts that one out. And technique, yes, but also TENS is a really simple modality that's very easy to learn and to apply. And so I think that limitation is less limiting. Mixed OA locations, I think, is very significant. So it complicates the outcome interpretation, especially since OA at different sites could respond differently to treatments. Only kinetic parameters were measured. No data on subjective pain scores or functional outcomes were reported for TENS, even though they gathered this information. So I mentioned that earlier. Why did they not share the results of those pain inventories in the study? I think that's interesting. And then what is the clinical significance for veterinary rehabilitation therapists? So GPT says, while disappointing at face value, the findings are important for guiding evidence-based practice. TENS should not be relied on as a sole intervention for improving gait in dogs with OA, especially when targeting objective gait changes. Now, do I agree or disagree? I agree. I wouldn't use TENS as a sole intervention. I would definitely want to, if I'm using, less modalities and I'm trying to empower my owner, TENS would at the minimum be paired with therapeutic exercise at the minimum. So yes, I agree. This does not mean TENS is ineffective for pain management. It may still have subjective or neurochemical benefits not captured through gait analysis alone. Again, I agree. I agree with this point that ChatGPT is pulling up for us as clinical relevance. This study alone is not enough to say that TENS is ineffective. It is effective for pain management. It is not the most effective tool that we have in our toolbox, but there have been enough studies showing efficacy. We need more specific studies showing efficacy in dogs, but it is a good inclusion modality in specific cases. Customization is key. If TENS is used, expectations should be managed and it should be interpreted into a multimodal rehab plan, not used in isolation. So again, I agree with that. From my side, TENS does not provide long-term pain relief. It provides short-term pain relief, which is why I would pair it with a therapeutic exercise program, because to me, that is where the greatest efficacy lies. And managing your owner expectations around that means you're going to have the best outcome for the patient. TENS may be more suitable as a short-term adjunct to provide relief during flare-ups or to support exercise tolerance, but its utility for measurable gait improvement is unproven. Yeah, I agree. Again, this is a tool that an owner can easily reach for during a flare-up or to support exercise tolerance. I like it. So I agree with all of those points that GPT made. Do you? Please tell me. This is, I am really experimenting with using AI. One of our biggest concerns is that it isn't accurate and that we're going to end up making clinical decisions that are not based on reality. So let's just be super critical as we go through this. I'm not letting ChatGPT guide my thinking, but I am trying to find different perspectives or gaps in my own thinking that I might not have identified initially. And it is super good at doing that. So there we go. So additional points for critical discussion. The placebo protocol, devices in the placebo group were applied identically but not turned on. The physical setup may still have had a mild tactile stimulus or placebo effect that could blunt detectable differences. I don't know. The owner would be potentially stroking and loving and massaging their dog during that time. So that could have an effect. Objective versus subjective outcomes. No post-treatment pain score data are presented. These could be more sensitive than gait data to detect subtle improvements. What is really important to me is that we don't actually discount the owner's perception of treatment efficacy. Yes, that is not necessarily an accurate reflection of the condition of the patient, but the owner's mental state, the owner's perceived efficacy of a protocol is super important for us in determining which protocols to include, what to incorporate. So I think subjective outcomes are actually really important when it comes to that owner feedback. The NSAID validation step, even the NSAID treatment only marginally changed gait parameters, only that one parameter, suggesting that gait parameters may be relatively insensitive to short-term pain relief, or that chronic OA gait changes are more ingrained. So there's a thought, right? We have really ingrained changes to the gait pattern on a neurological level, on a physical level. So only providing pain relief doesn't change that. We need to be specifically targeting those gait patterns. So that's something to think about. And then it outlines some future research directions.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. A big thanks to our sponsor, Paw Prosper. Their sponsorship allows us to be able to give this podcast to you for free, so please go and check them out at pawprosper.com. Don't forget to bookmark the next Vet Rehab Summit on Saturday, the 8th of November, 2025. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehabber community. Onlinepethealth members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com.